morning, everybody. This is Donna Prosser with the Patient Safety Movement Foundation. It's just at 8 o'clock and we are getting ready to get started here very shortly. Give us just one more minute to get everybody else in that's waiting to get into the webinar. So we're gonna. Good morning, everybody. All right, this is Donna Prosser with the Patient Safety Movement Foundation. Welcome to our second round of our webinar for the coronavirus update. We have several speakers here with us today. We're very excited to have everybody. Again, my name is Donna Prosser, and I'm the Chief Clinical Officer here at the Patient Safety Movement Foundation. Can everybody hear me okay?
Yes, I can hear you.
Okay, I'm sorry. We just got a message that says that we're muted, so my apologies there. Okay, so let's go ahead and have everybody on the speaker panel introduce yourselves. Let's start with Mitch.
My name is Mitchell Goldstein. I'm a professor of pediatrics at Loma Linda University Children's Hospital.
Great, thank you, Mitch.
Hi, do you want me to just start? This is Robin Betts. I'm the Vice President of Quality, Clinical Effectiveness, and Regulatory Services for Kaiser Permanente in Northern California. I'm also a board member of the Patient Safety Movement Foundation.
Steve Barker, anesthesiologist and former chairman at the University of Arizona, also Chief Science Officer for Massimo Corporation and board member of the Patient Safety Movement.
Thanks, Steve. Welcome. Art?
Yeah, thank you. Art Kanowitz. I am the founder of the Airway Safety Movement. I am on the chair of the Patient Safety Movement Foundation Airway Safety Work Group, and I am the founder and chief medical officer for Securison Medical.
Wonderful. Mike Durkin, are we able to hear you now? Mike? Okay, we're going to come back to Mike in just a minute. We just need to get him unmuted. And Jerica? Okay, we have to get Jerica unmuted as well. So, we will come back to those folks. One exciting thing today that we are happy to announce is that Dr. Ed Kelly from the World Health Organization is going to be joining us at about 8:30 to talk to us about what's happening in the rest of the world and what we can do to prepare in those areas that have not been hit hard yet. Okay, and Steve, do you want to tell us about this map?
We're not seeing a screen, Donna.
You're not seeing my screen?
No, nobody is. You've got several chats. Nobody's seeing it.
Just a moment.
Okay.
Can you see me now?
Yeah.
Now we're getting there.
Okay, my apologies, everybody. We bought a new program because last week we didn't have enough capacity for folks to join in, so we've got a new program this week, and our apologies, we're still working through some of the bugs, but thank you very much, Steve, for letting me know that. Go ahead and talk about the slide.
Sure. This is my favorite updated screen on incidents and deaths. It's run by Johns Hopkins University through ArcGIS, and it's updated about every 2 hours. As you can see on the upper left, the total number of confirmed cases is up to 137,000. you see the leading cases by country in that left-hand column, and you see a map which is a good visual of the total case incidence by region. You can also zoom that map by pinching, and can you try that, Donna? Do the,
You see that?
or you're going to go to the,
My apologies, my
yeah,
apologies.
you
I just hit the wrong thing. It's coming,
okay.
coming.
Yeah, we're going to get the live screen on so you see the real thing. And there it is, hopefully.
Can you see it now? It's coming. It's just
Yeah,
taking a minute to load.
there it's coming. Okay, so if you have a touch screen, you can pinch and zoom. You can also, good, now make it larger and scroll over to the US as an example. There you go, and that'll fill in. You can see the US incidence by region. The western states have kind of led, but the eastern states are catching up if you look at the last several days. Back to the cases by country, China obviously is leading by far. That's where this started in Wuhan. Iran was second for the first month or so, and Italy has now taken over second place. And you can see they're well into second place. The questions are always why. Apparently there is, or at least was, a lot of travel between Italy and China. If you move over to the right-hand columns, you see the total deaths is over 5,000. And again, Italy has taken over second place by far in deaths. They were behind Iran until fairly recently. Total recovered is growing rapidly. And then the last thing I'll comment on is that graph in the lower right. In fact, if you double click on that, it'll get larger. Well, maybe not. Click on the actual where it says actual at the bottom there. Yeah, try that.
Nope, sorry, Steve.
Okay, that's all right. It's all right. I'll just talk through it. You see three curves there. The orange curve, the highest one, is mainland China, and as you can see, that's leveled off. If the data are reliable, then that's a good sign. The yellow curve, which is just really starting to go up exponentially, is the rest of the world. And if you blow that up, you see the slope is now relatively constant. So we certainly haven't started. There you go. Good job. All right. So you see the yellow curve has not even started to level off yet. That's the one we're concerned with. And we'll be hopeful. But this I find is very helpful. I check it a couple of times a day. It's updated. I believe it's accurate. The only thing you have to ask, of course, are all the countries equally accurate in reporting and updating their data? And we don't have the answer to that, but it's the best data we have. So I recommend this site highly. Thank you. That's it.
Thank you, Steve. I appreciate that. All right. All right. And now I believe that Jerica should be unmuted. Jerica, are you able to hear me? Jerica? And Mike, how about you? Are you able to hear me now?
Yeah, I can hear you, Donna. Can you hear me?
I can hear you. And so,
Great.
yes, thank you so much. Can you just tell the group a little bit about yourself?
Yeah, so certainly. So my name is Mike Durkin. Currently on the board of the Patient Safety Movement Foundation and an advisor on patient safety policy and leadership at Imperial College London, and also supporting WHO in leading a global patient safety collaborative supporting lower middle income countries across the globe. My previous substantive role was as the National NHS Director of Patient Safety for the NHS in the UK. Thank you, Donna. Yeah, in terms of where we are in the UK and Europe, you can see this from many of the websites that are going on at the moment, but we have certainly now moved to a different position, one of where we have been very conscious of trying to do a lot of testing for those with symptoms, and usually testing in sites that are convenient for local populations, and those testings have demonstrated that we currently, although we've tested over 20,000, we currently are just over 600 known cases of coronaviruses, and we have had 10 deaths to date, although that might change daily. What we've decided to do as of last night is to move that testing scenario to suggesting to all people who have demonstrated a temperature rise, a high temperature of over 38, and symptoms to self-isolate, so to stay at home, and where they are within a family who also had symptoms, to all stay at home together. That's an element of change that we've introduced over the last 24 to 48 hours. So we're now suggesting that routine testing for our population will only take place once people have gone to a healthcare setting or have been admitted to a healthcare setting. Otherwise, out of hospital testing, we will slow down, but concentrating on asking people to stay at home, remove themselves from work, and carry out the usual processes for social distancing.
Excellent.
We've also introduced elements of change in terms of our sporting events, but we have not yet introduced a closure of schools or colleges, which I think is different from a number of other countries of similar size.
Excellent. Thank you so much. I appreciate that. Jerica, are you able to speak now?
Yes, hi.
Hi.
Can everyone hear me?
Yes.
Hi,
we
oh,
can.
I'm glad. I apologize for the technical difficulty. Yes, so just to echo what our previous colleague has mentioned, in terms of the background of COVID-19, as we all know, on March 11th, the World Health Organization declared this as a pandemic, basically pushing the threat beyond the global health emergency that it has announced in earlier times, like in January. And as we all know, this is a result from the fact that at the time of this announcement, the coronavirus has infected more than, right now, it is more than 130,000 people and has affected over 114 countries. So the numbers are expected only to rise, especially in the US, as more testing kits become available. And what we found out is that because of the increasing clusters of COVID-19 cases, social distancing, which will be talked about further later in this slide deck, is strongly recommended for everyone at least 6 feet from one another. This also means that universities are moving on to online instruction. Public schools are closing. As I hear this morning, there are 5 states that have closed the public schools from K to 12, the high school senior year. In many of the states, large gatherings have been canceled, such as concerts. We've heard about South by Southwest in Texas and Coachella in California. We've also heard about the travel ban that's coming down this near midnight tonight from 26 countries in Europe, and cancellation of sporting events such as the NBA games, church services. So I think that the takeaway from this is that it is definitely a pandemic, and we should take a lot of precaution to make sure that we don't transmit this virus if we're asymptomatic and are unaware, and also put ourselves at risk for being infected.
Yes, thank you, Jerica. I appreciate that, and I'm hopeful that when Ed Kelly joins us, we're going to be able to learn a lot more about what other countries have been doing to mitigate or to be able to manage the social distancing that we need. Thank you. Next slide for you.
Yes, so about 2 days ago, Governor Gavin Newsom of California has also issued a policy on gatherings to protect the public health and to slow the spread of COVID-19. This is a state's public health issue, not like a mandate, but more of a policy that basically all mass gatherings and large gatherings should be postponed or canceled across California until at least the end of March. Non-essential gatherings must be limited to no more than 250 people, while smaller events can proceed only if the organizers can implement social distancing of, again, 6 feet or at least 2 meters per person. Gatherings of individuals who are at high risk for severe illness from COVID should also be limited to no more than 10 people, while also following social distancing guidelines. So the state's updated policy defines a gathering as any event or convening that brings together people in a single room or a single space at the same time, such as in an auditorium, stadium, arena, large conference room, meeting hall, even the cafeteria, or any other indoor or outdoor space.
Excellent, thank you. Appreciate that, Jerica. Okay, well, and in addition to what Jerica was talking about, you know, some of the background recently has been talking about testing. You can see here that in the United States, we were a bit behind in testing, but we're starting to pick up now. And so there's expectation that, that all of the testing that we need will be available moving forward. Mike Durkin, tell us about what you guys are doing in the United Kingdom for testing.
Yes, thank you. As I said in my introduction, Donna, we up until this date, we have been working our testing system through symptom management based on all people, population having access to a phone number called 111, which is an advice phone number for health that supports the whole of the NHS. And through that, the idea was that you'd ring that number, you describe your symptoms, then you would be given advice by a call handler as to whether or not you should go to a local testing center and be tested for COVID-19. We have been slowly increasing the numbers of call handlers as required by the numbers of people accessing the system, and we've now moved also to an online approach. So that people can describe their symptoms and then be directed through an algorithm approach down to whether or not they need testing or they should carry on or they should stay at home. As I said earlier, we've changed that process almost overnight, and now we're very much recommending that people who have demonstrated that they have symptoms and have a measured temperature rise, that they self-isolate and that they for at least 7 days, but stay in touch through the 111 system online or by call if their symptoms worsen. And in such cases, then they would be redirected to be taken in and given further advice. So we've moved that system quite clearly now. Thank you.
Thank you, Mike. Appreciate that. Yeah, so as you've heard, we've had a significant community spread at this point. We're beyond containment now and working on mitigation. Our hospitals in some of the hard hit areas across the world are quite overwhelmed. So those that have not yet been hard hit are preparing for increased capacity. And in a little bit, we're going to talk more about what hospitals can do about this. You've probably seen the empty aisles in grocery stores, which is probably not necessary for people to be doing right now. But again, when later on in the program, we're going to talk a little bit more about that. The other thing that is an interesting problem that we have now is that there is an acute blood shortage because we have limited donation at this point with fewer people venturing out, and EMS is also beginning to become overwhelmed. So and so as part of our recommendations discussion, we will address all of these. Mitch, you want to tell us about some basic recommendations for folks?
So one of the things that people need to recognize is that the disease can be mitigated, the risk of it spreading. And one of the important things is proper use of hand sanitizers or washing your hands. The first is a video which is from the CDC, and this goes into various techniques that you can use in terms of how to properly wash one's hands.
Did you
And
want me
the
to show
other
that,
is,
Mitch?
I know, I think we'll go through because
Okay.
that's going to be a minute and a half,
Yeah,
but
yeah.
I want people to have that link.
Yeah.
And the other is a simple 20-second countdown, and people can use this if they want to get an idea of what 20 seconds really is. We could show that, I think. And I'll talk over it. And so as you could see, 20 seconds does represent a considerable amount of time. People who are bored by this countdown can sing happy birthday twice, or perhaps the alphabet song twice, and that'll get you through this 20-second interval, which again seems like a short time, but is at times long. So we'll go back now to the slideshow.
Okay.
You want to try to avoid touching your face. This is something that's very, very hard to do if you've ever tried not to do it. But again, it's something that we should cognizantly do and try to practice if at all possible. Staying home when it's not necessary to go out. And again, this is not something that's easy, especially if there are things that you want to do or want to go, or places you might need to be or really don't have to be. Again, calling in, teleconferencing, webinars, that's the more practical way of doing it. Don't wear a mask unless you're sick or caring for someone who is sick. And again, you've seen the proliferation of ads in media campaigns and on the web. In some cases, they're charging a premium on pricing. But a lot of these masks are not the ones that are necessarily going to protect you against COVID-19. Really, you need a very high-end N-95 mask in order for there to be true virus protection. So that said, given that you only really have 3 or 4 minutes before that mask becomes ineffectual, you want to avoid using it unless it's really necessary. There are other sites that are important. This is the World Health Organization Basic Protective Measures Against the New Coronavirus site, which is a very good site to look at. And it gives you general advice for the public. The other is one on environmental cleaning. Now, I want to emphasize that if you're washing your hands, a 60% alcohol solution is deemed adequate. But if you're using sanitizers for environmental cleaning, there are some recommendations about using bleach and how to mix the bleach to effectively eradicate virus. But also, if you're using an alcohol-based solution, you want to use one that's actually 70% as opposed to the 60% alcohol that you're using for your hands.
Excellent. Next slide.
And this is just a diagram showing how virus spreads. We've talked a little bit about social distancing, and I'll talk a little bit more about it later. But if you look at the droplet spread from someone who's sneezing, and I believe that's what this guy is doing, you see how the highest density is close in, but really you can get particleization or aerosolization out to 6 feet. So in social distancing, you do want to try to work at home whenever possible. And a lot of the companies, a lot of the firms are trying to make it so that people have this as an option. Commuting by way of phone or by way of teleconference is oftentimes a perfectly acceptable way of getting business done. Avoiding large gatherings whenever possible, and Governor Newsom in California, as you saw, has restricted gatherings to less than 250 people. And again, at these gatherings, if you're there, wash your hands, don't touch your face, good practices for keeping social hygiene. When you're at these places or when you have to be among people, try to observe the rule of 6 feet of spaces around you. So again, this is something that's increasingly hard to do in a lot of these spaces that have seats one on top of another. But again, from a standpoint of reducing the risk and reducing the spread, this is an important way to do it. Self-quarantine, if you're worried that you were exposed or if you are feeling symptoms, and these symptoms may mimic the flu. You may have GI symptoms as well as cough, cold, congestion. It's like the common cold. But you want to ensure that before you do this, that you have a 2-week supply of food and prescriptions. We've heard of the runs on toilet paper and paper towels and hygienic type products. But again, this is something that people need to do within reason. And again, Amazon and other services which deliver by way of mail or by way of courier may be ways of getting the necessary supplies. Where do you quarantine? Well, if you can, you want to quarantine at home. And one important thing about social distancing, and a very important thing about this as well, is that if you're sharing your home with other people, you want to try to, if at all possible, to stay in a room by yourself. If you can't, again, observe the rule about 6 feet distance. You want to, again, obey all the things that we talked about in terms of washing your hands regularly and not touching your face. And below is the CDC community mitigation strategy, which includes these points and many others.
Thanks, Mitch. And you want to talk about this slide?
I'm sorry, do you want me to talk about it, or?
Oh, yeah, I'm sorry. I certainly can if you don't, if you, I'm sorry. Yeah, this is, Mitch, this is the 1918 influenza pandemic that, was in the United States. This is really seriously the last time that we had a significant pandemic like we do now. And so in the city of Philadelphia, they did not practice social distancing, but in the city of St. Louis, they did. And you can see here that there was quite a spike and quite a significantly higher number of deaths in the city of Philadelphia than in St. Louis. So this just goes to exactly what Mitch was just talking about social distancing and why this is so important. So it's not so much that we're staying home to prevent ourselves from getting sick, as much as it is we're staying home to prevent this kind of peak in transmission in the world. So again, I'm looking forward to talking more about that in just a little bit. Okay, and so Art.
Yes, thank you, Donna. So populations that are high risk for more serious COVID illness, everyone is at risk for getting the virus. There are some populations that are at higher risk for getting the virus. And then those that get the virus, many people have mild illness, but there are those populations that are at risk for getting much more serious illness, including severe respiratory compromise and death. Those that are at higher risk are certainly the older adults. Based on early data from China and from the CDC, the data suggests that older adults, and typically we're talking age 65 or greater, although that's not a hard number, are twice as likely to have serious illness. And as we've seen in Washington State and many other places as well, you get older adults that are near each other due to being in a senior care residence, and many of them having underlying serious chronic illnesses. They're certainly, those people who are in senior care homes are certainly at higher risk for getting the disease and more severe reaction to the virus. Other groups that are at higher risk are people with severe chronic conditions, certainly those with chronic lung disease, especially those groups that have been hospitalized in the past with respiratory illness are at increased risk. And then those chronic lung disease like COPD, interstitial lung disease, and asthma. Certainly those groups that are either immunocompromised due to an underlying illness or immunosuppressed from medications, those patients that are transplant patients, all the autoimmune diseases like rheumatoid arthritis and lupus, and certainly those with weakened immune systems like HIV, they're all at risk for more serious illness. And then chronic medical conditions such as heart disease, diabetes, and chronic kidney disease as well are all, again, at increased risk for serious illness.
Great, thank you, Art. Mitch, do you want to talk about the next slide?
Sure, there are special considerations for certain vulnerable populations. And although there hasn't been reports of large numbers of pregnant and lactating moms being involved, it's important to know some of the factors that may be of concern. The virus has not been isolated from breast milk or, for that matter, from amniotic fluid. And although lactating mothers can continue to give their breast milk, the procedures that they should follow should involve taking as much precaution as possible. And so, in so much as it would be nice for the baby to go to breast, that might represent a risk of disease transmission. While they're infected, women are therefore recommended to express, and if possible, at times to have somebody who is not infected perhaps aid them with expressing their breast milk for their baby. Or again, another option is to formula feed if the mom is too sick or for some reason otherwise incapacitated and unable to provide breast milk. With respect to newborns and infants, there have been anecdotal cases of neonates being affected. These babies are at risk, especially if they are premature because of the fact that they may have an altered immune system. But for some reason, this seems to be affecting more people who are in the older age groups. And again, does not necessarily mean that there's not a risk, because again, you would expect that common factors are being provided. Newborns are also at risk for a number of the other seasonal viruses, including flu and RSV. So a lot of the neonatal intensive care units have put precautions in place, which remain in place and have likely mitigated the spread of COVID-19.
Thank you. Appreciate that. Okay, and Robin, can you tell us what hospitals need to be doing now to prepare?
Yeah. Thank you. I think, first you need to assess your facility's infection control program and assess your personal protective equipment supplies and optimize them, and really work with your infection preventionists to build a program based on what we know about the virology and the epidemiology, how it is spreading within your community. I will say that the CDC has wonderful guidelines around potential mitigation activities that are linked to the level of your community transmission. So going back to that original map, you can see the bubbles where you have no spread to small spread to very large spread. So in Northern California, we're one of the hot spots. One of our counties got a personal mail letter from the CDC yesterday to incorporate more restrictive and tightened policies around how we are managing our patients. Currently, for patients that are suspected of COVID and have respiratory infections or symptoms, that we evaluate for them for hospitalization. If they do not need to be hospitalized, they're asked to be kind of self-isolate at home. If they are admitted to the hospital, you place a mask on those people. It doesn't have to be an N95, but really to protect from the release of their droplets should they cough or sneeze, because remember, this is droplet transmission. And it is recommended by the CDC that currently that we place them in rooms. If you don't have negative pressure rooms, to place them in a room with the door closed. Or if you do have airborne isolation rooms that have negative pressure, those should be, and they're limited in supply, so you're a smaller hospital, you'd want to reserve those for patients who will be undergoing aerosol-generated procedures. Another thing that you can do is cohort patients with like conditions, so that you limit the number of your staff who are caring for people who are suspected persons under investigation, as they call them, PUIs, and COVID positive. So you can designate portions of a unit or an entire unit to housing these individuals. And that way you cohort them and limit the number of staff that are exposed to the virus itself. I know that especially smaller organizations that don't have the buying capacity of large organizations, there are concerns about supplies of respirators and N95 masks. And so again, the CDC has provided some wonderful guidance of ways that you can preserve your stock holds. They recommend using expired N95 masks under the guidance that they must be checked for integrity and wear and tear and any and do a seal check prior to using them. So that's one way. One thing that we did is we did check the integrity of the expired masks, and we used those to do our fit testing, and then used masks that were not expired for to keep them within the supply of our caregivers. Another I guess, supply sparing opportunity that the CDC recommend is that during times of limited access to respirators or face masks, facilities could consider having your healthcare providers remove only their gloves and gowns and perform hand hygiene between patients with the same diagnoses while continuing to wear the same eye protection and respirator or face mask. And then there would be instructions and guidelines around not touching your eye protection or your respirator equipment. So there, like I said, there's tips to help in preserving your supply. One thing to consider is when you're moving patients around your hospital to go for other tests or radiology or things like that, that the patient should wear a face mask to contain their secretions during transport. And then in the end, of course, we always want to clean. And so make sure that the room goes through a terminal cleaning at the end of a COVID patient. And one of the things there was a question, I believe, last time around how long do you wait to go in and clean to let the room settle? And in doing research, we do not know how long yet the COVID virus will remain ambient in the air. However, have a policy around it. So my organization has a policy that we close the room and we let it wait 1 hour before we go in and clean, hoping that the virus will settle into the surfaces and be clean. Just a couple other things. As you anticipate surges, I think the key word here is anticipate. So implement how you would triage individuals in a rapid cycle. So you could establish a process to evaluate and test large numbers of patients in a external to your environment to screen if they actually need to come into your clinics or your hospital. So some of the things that we've done here in Northern California is we have people call in and get triaged based on their symptoms, and then we have a drive-up testing center. If they meet criteria, they will have a prescription and be told to meet external to our buildings, and they will be tested for the virus and then sent home to continue self-isolation unless their symptoms exacerbate and they have concern for their health, and they would come back into the hospital. So what would those kind of quick screening or triaging places, what would they look like, and where would you place them based on your regulations? And I recommend getting your permits in advance. Also in your hospitals, if you want to flex, for instance, we do have a hot spot. We're getting a lot of patients. So we had some shelled areas that were ready to build out and implement, but we never licensed on the space. You can look at, or we licensed it, but we never opened it as a unit. So you could look at getting that flex to now move patients into there since they are licensed space. We looked at if we're moving from having elective surgeries, could we use our post-op care areas to manage these patients and cohort them in a contained area, again, limiting or restricting the number of people that come in contact. Visitor restrictions are really important at this time to reduce transmission. So it's really important that you have, you revise your visitor policy that limits the number of visitors. And it really, you need to consider unit by unit because, for instance, a laboring mother, it's very exhausting sometimes if it's a long labor, if they only have one support person. So you might want to allow you know, a you know, their spouse or their significant other, and then they may have a nurse practitioner or a laborist who they've identified that they want with them in the room. And so really allowing some flexibility based on unit. So don't, you know, really think about your visitor policy, but have a way of screening them for their current conditions, as well as educating them on infection prevention and, you know, the hand hygiene, and then also to restrict their movement. Really ask them to, you know, go from A to B and kind of hang there. And then there's ways to bring nourishment to room. You might think about how you bring nourishment to the rooms instead of having large people congregating in your cafeterias. So these are just some of the ideas of things that are happening now. Also, just to limit the volume is think as a leadership strategy of what you can do to reduce your elective volume. And so and those are really driven on your community transmission, but in some places we are limiting elective procedures where we have some areas that are more remote and they have been not impacted at all by this virus. So I think that pretty much sums it up for me.
Great.
But I just want to say, I think getting those permits early so that you're not reacting when people come, but you have a plan when the surge begins to happen or things begin to build. And then you're in much better position than if you waited until you began to feel the surge and you weren't able to support it. I will also say that your infection prevention resources are usually just a few people in your organization. While they're managing this outbreak, the eyes can come off the ball of your infection prevention program. So thinking about how you'll support those ongoing surveillances and audits and rigor around your regular program will be really important.
Great. Thank you, Robin. I
Yeah,
appreciate
thank you.
that. Great insight. All right, well, we are very fortunate that Dr. Ed Kelly from the World Health Organization was able to join us, but we just have a few more things to talk about regarding treatment. So Art and Jerica, if you could just real quick go through what we can expect in terms of treatment for these patients, and then I'd like to ask Ed Kelly some questions as well.
Sure, thanks, Donna. So thank you to Robin for doing such an excellent job on her part she just did. I'm going to skip the first bullet point since she did a great job on talking about personal protective equipment. Just a couple other special considerations for healthcare workers who are treating whether it's suspected or known coronavirus patients. One of the things we don't think about a lot is, are we carrying some viral particles out of the hospital on our clothing? Yes, we try to do a great job with our personal protective equipment, but that doesn't always totally isolate our underlying clothing. Some hospitals actually have mechanisms for you changing out of your clothing before you leave the hospital. But if you're wearing your clothing home, I would be careful of trying to get that into the washing machine or isolating it somehow very quickly so you're not moving that particle onto your other places at home. The other thing, just real quickly, is, and we don't think about this a lot, but there are some treatments like using nebulizers. Certainly a lot of the patients who have severe asthma or COPD and are requiring nebulized treatments, their symptoms may overlap with those of viral patients. These nebulizers can off-spray a lot of viral particles. So these things should only be used in negative pressure isolation rooms, or if you don't have such, certainly in a single room. I certainly would be really careful doing that in a main emergency department. And clearly we've seen a lot of the ambulance services throughout the United States who are now having their patients use their multi-dose inhalers rather than nebulizing them in the ambulance and waiting to get to the hospital. Similar kind of thing with non-invasive positive pressure ventilation like CPAP and BiPAP. same kind of considerations. Be careful that these things aren't spraying particles and putting other patients at risk.
Great, thank you. Jerica?
Yes, hi. So another form of a treatment strategy, just to segue from Art's great description earlier. Right now, with respect to antiviral treatment, unfortunately, there is no specific treatment for COVID-19 at this time. What we know is that at the present, we need to treat COVID-19 like a severe form of influenza or a viral pneumonia, where we should use high supportive care and treatment, as well as respiratory support with oxygen ventilation for those diagnosed and hospitalized in various medical centers. Specifically to the antiviral agents, there are current data out there, but they're primarily in vitro data, especially with chloroquine, which is an anti-malarial drug. We have some in vitro studies that have demonstrated that chloroquine can interfere with endosomal trafficking and have worked against the coronavirus, especially it was studied against SARS and MERS at the time. However, there's no human data yet. So right now, there's not a lot of evidence supporting this drug for COVID-19. The other one that is currently being in clinical trials, there is one in the US, it's called remdesivir, and it's also being studied, I believe, in China and also a place in Italy. It was approved as treatment for Ebola infection last year, and remdesivir is a novel nucleotide analog that has activity against the coronavirus, CoV-2. In vitro data have demonstrated that it's pretty successful against that virus, and also related coronaviruses such as SARS and MERS as well. And again, these are in vitro and animal studies, so we don't have, it's not prime time yet to use remdesivir for humans, for humans, and it's not available for public access. The one medication that I want to highlight, which I apologize is not on the slide, is an old protease inhibitor, an HIV drug called Kaletra, and it's a combination of lopinavir and ritonavir, and it's also been used against SARS in 2003. There's a small trial held that was conducted in Singapore using Kaletra at low doses, and the results as well as efficacy were unclear against COVID-19. So what we're suggesting right now is, again, supportive care and respiratory support for those who have been hospitalized.
Excellent. Thank you, Jerica.
Mm-hmm.
Okay, and Ed Kelly, are you on the line now? Can you hear me? Ed?
Yes, I can hear you. I just had to take myself off of mute.
No worries. Thank you so much for joining us. I really appreciate your time today. I think we're ready to move on to the question and answer session, and we have lots of questions for you.
Good. I'm happy to be here. And you know, just a quick word. You know, we've had a long relationship with the Patient Safety Movement Foundation and with Joe and the team. And actually, I was on a call with Joe and Dr. Tedros, our DG, yesterday. And when I learned about the webinars that were happening, and so very happy to contribute. And it's really just a repayment for everything that the foundation's done for the organization and the partnership we've had on safer patients over the years. So over to you.
Wonderful, wonderful. Thank you. Well, there's, I wonder if you could just kind of give us an idea of what it is that you're seeing across the world in terms of what countries are doing well and what countries may not be doing well that we can all learn from.
Yeah, there is some, obviously each country has very different sort of society, health system and approach. I think it's obvious that the countries that are doing a good job in WHO's minds are the ones who really jumped into their response on this, robustly supporting frontline health workers, supporting hospitals, getting testing out there as quick as possible, and you know, really taking it seriously and understanding what the scope of the problem was, and then you know, considering measured approach. You know, WHO has this 4 C's approach where you have first you just have isolated cases, then sporadic cases where you're spreading, and then clusters of cases, and then down to community spread. And so obviously, you know, we're given in our current world, we see stories of community spread, even though we're living in a country where there's only still sporadic cases, and people's reactions happen accordingly. But I think as healthcare professionals, our job is to really let people know where we are, and let people know that it's going to be a big wave that's definitely coming, but that we're trying to get ourselves ready as quickly as possible. And there's definite ways to manage this as it goes forward. So Korea has done a great job testing 20,000 people a day. They have very strict measures that are in place, but they are not confining people to their homes. They have a lot of cases, but they've been able to manage, and people are getting on with their life, even though they didn't perhaps jump on things as early as possible. Now you have other countries that have been less able to get out in front of it, and you can see that's the case in Italy and Iran, where things are very difficult. Luckily, and then I'll turn it back to you, some of the countries that got hit the hardest first have actually quite strong, they're wealthy countries. China is a wealthy country, Korea, Italy as well. They've got really swamped. And so, it's given us lessons for the countries who are going to have a much harder time reacting.
Excellent. Thank you. Thank you. Well, we have a few questions from the audience. Two questions in particular about working in hospitals. How do we ensure the safety of healthcare workers if other folks are not following precautions, was one of the questions. And then another is about wearing surgical masks during working hours. So I wonder if someone would like to answer either of those about how can healthcare workers keep themselves safe while they're working?
Steve Barker, just a quick comment. My wife actually works in primary care, and the kind of sad thing is that all of these people with flu symptoms that are not acutely ill, but they've got flu symptoms, including fever, are coming into doctors' offices to be seen. And I know the recommendation from the CDC is that if you have symptoms, but you're not terribly acutely ill, you should just stay home and not expose other people. I think that's an important message we got to get out to the public.
Excellent, thank you.
Yeah, and can I jump on that too? I think this is just a quick comment that it is about how each individual health worker kind of understands and all levels of the healthcare team, because obviously you're going to have contact with people as they come through the emergency room, as they come into your outpatient clinics, et cetera, understands appropriate personal protective equipment and IPC procedures. But so it's a chance, like the earlier speaker was saying, about really emphasizing that IPC work. But most of the successful setups are that even at primary care level, you figure out some way of very early triaging anyone with flu-like symptoms, and they're in one room. And so there are ways of managing it. In Italy, for instance, people have a right to see the primary healthcare physician the day that they're there, and they had to rewrite the law to actually say that they have a right to see a triage person and first. So I think that's this role of early triage. And sometimes in some of these countries where you're seeing tons of cases, that involves a tent outside or a different structure outside the regular triage area.
This is Mitchell Goldstein. Another thing that we've seen locally at a number of the area hospitals is running short of certain critical supplies like masks. And again, when we look at it from a standpoint of engaging with patients and in some cases having to restrict the activities of students and residents in terms of engaging so that we can save and conserve materials that would otherwise be used up at a larger pace. So some part of it is just common sense in terms of recognizing when shortages of certain supplies are occurring, and even at a local hospital level, restricting access of care providers to those who are the ones who are absolutely necessary.
And what about elective surgeries? Is there a recommendation to hospitals to cancel elective surgeries at this point?
I'm not aware of a recommendation like that. Are you, Steve?
Ed, do you know if that's a recommendation?
As for WHO, we have just finished some work. And by the way, both CDC, I'm sure people have seen it, CDC, as well as some of the state public health agencies, and also WHO. And we'd be happy to share this with the foundation for blasting out to folks who are on here. There's have tons of really, really good resources on this, from resources for the public as healthcare providers and managers. But in countries where you're moving from clusters of cases to community spread, it's not a question of preventing infections in the healthcare setting necessarily. It's really a question of capacity. We have recommended to a bunch of countries that they consider the sort of a very analytical and differential approach to elective procedures that could take up bed space in your hospital. So you have, in a prediction by ECDC today, is that most European countries will have issues managing bed capacity in their hospitals, given the current rate of spread in places like France, Spain, Germany, Denmark, et cetera. So it's definitely a real concern. It's not something that the US is at that level now, but it's something that you should have a plan for.
Excellent. And so then, can you then talk a little bit about the whole concept of social distancing and how that relates to hospital capacity?
Yeah, but maybe that folks, other folks on the call would be definitely in a better place for that. But I think that I think we do have to remember the way that we will manage the outbreak is by case identification and contact tracing. I mean, that's social distancing is an important thing to get the public involved. Also, there are good procedures in addition to good IPC, good decontamination approaches in hospitals. But it's only one. Anyway, it's one piece of it. But I think there is, hospitals should send the message that is being sent out that businesses are doing, all the other organizations out there are doing. In terms, you obviously can't work from home. That's the whole point. But you can set up ways of examining, where do you really have high traffic areas and trying to manage things differently.
Okay, great.
Yeah, I'd like to add one comment to that. You can't work from home, but actually there is the option that we need to explore more, and that is telemedicine, where routine clinic type appointments, primary care especially, can be done remotely. And in Arizona, that's very common because there are a lot of remote locations, such as Indian reservations, where doctors, especially specialists, are not readily available. So think about telemedicine.
Yeah, I think just to add to that, that's every crisis like this presents us with opportunities for learning new ways of doing things. And for sure, we should have been moving this way a long time ago to reach hard to reach populations anyway. But I think it'll really push, anyway, looking how you can push some of your the geeks you have working for you in your IT department to explore some ways to do this. Now, it's difficult to roll out new ways of doing medicine in the middle of an outbreak, but at least to start to look at some of that is really important.
Great. A few last questions here. One question is regarding COVID and sepsis. Are patients that are dying of COVID actually dying of sepsis or of some other respiratory situation? Maybe Art? Do you know the answer to that?
Well, I think in general, most of our sickest patients are dying from complications of the pulmonary aspects of the disease, rather than what would be considered a true sepsis. But I don't know that I have any facts to support the comparative number of people with COVID that have sepsis versus, pulmonary failure.
Okay, excellent. All right, well, we are right at the top of the hour, and I want to thank everybody for joining, and our panelists. Thank you so much to all of our panelists this morning, and all of the great information that you shared. As we did last week, we will send out this PowerPoint in a PDF version to everybody who attended, so that you can have the links that we shared. And this information will also be put onto our resources page, our coronavirus resources page at the Patient Safety Movement Foundation. We will be here again next week, and we'll be doing this webinar every Friday at 8 a.m. Pacific Standard Time until the coronavirus outbreak is under control. So again, thank you to our panelists. I very much appreciate your participation today.
Thank you very much, Donna.
Thanks.
Thank you.
Thank you, everybody.
Thank you, Donna. Thank you.
Thank you.
Bye. Have a good weekend.
Bye-bye.
Bye-bye.